Well, thanks for coming back to Oracle TV here at HIMSS in Las Vegas. And my next guest, I'm a big fan of Dr. William Paiva, who's the executive director of the Center for Health Systems Innovation at Oklahoma State University. I should have worn my orange for you.
I know, it would have been great. And I should have worn like a orange handkerchief or something.
Yes.
We didn't do as good a job as we should have to coordinate.
We didn't, but I do.
But we do have a yellow hanky to match your outfit, so I did the best I could. So
I love it. I love it
we
so
are.
much. And thank you for being here.
Of course.
It's honestly
my pleasure.
always a joy to talk to you. I just smile when you come around.
Aw,
So
thank
just
you.
know that we're a big fan of yours here.
Thank you.
Okay.
And me of Oracle. We'll get into that.
Yeah,
So,
absolutely. Well, let's talk about that because, I think it's so unique that your center sits at the intersection of business and clinical innovation with a bold mission to transform rural and Native American health.
Yeah.
So let's start there. Can you tell us a little bit more about the communities you serve?
Of course. And to do that, I need to provide a little bit of context because I think it sets the stage.
Absolutely.
So prior to launching the center at Oklahoma State University, which is about 12 years ago, I was a venture capitalist and still operate a venture capital fund. So for 26 years now, I started in 2000. So for 26 years now, I've been running a venture capital fund, investing in some of the leading, most innovative companies in drugs, devices, diagnostics, technology-enabled services. So it's innovation and health innovation has been in my fiber for a long time. And so I came at this job from the context of a venture capitalist and an investor in startup healthcare companies. And for 26 years, I've seen almost all innovators focus on urban healthcare, right? Well, why do they focus on urban healthcare? It's where the people and money are, right? Why does Willie Sutton rob banks? Well, Willie Sutton robs banks because that's where the money is, right? That's where the innovators focus on is urban healthcare. And unfortunately, rural markets, in our case, rural and Native American, because those Venn diagrams overlap quite a bit, unfortunately, the rural markets get overlooked. We love talking health disparities. The number one health disparity, I would make the argument, is rural healthcare. 20% of America, 66 million Americans live in rural markets dealing with inadequate healthcare. So as a venture capitalist, I looked at it as an untapped market, right? That's what I was like, okay, that's a $66 million person market that's untapped. So let's go after that. And it also supports our land grant mission at Oklahoma State University. Oklahoma State is a land grant university designed to service all things rural. Oklahoma is a rural state. So for all of those reasons, it pointed us to go after rural and Native American markets.
Wow. Thank you for the insight there. I mean, you worn many hats.
Yes.
And I think it's so interesting how you've crossed over with those hats and took that into what you're doing and how you're working to transform healthcare.
Yeah.
And so when you look at this whole ecosystem that you just described and the community that you serve, what are some of the biggest challenges and opportunities that you see?
Yeah, great question. And, when I started the center 12 years ago, rural was an untapped market. Roll forward 12 years later, rural's the new hot market, right? Like it's amazing how rural's become a very important topic in our discussion on health innovation. And even the Rural Health Transformation Program that came from CMS that's funding into the states and being distributed within the states, the name is Rural Health Transformation Program.
Which we need to talk more about at some point.
Of course we can. And our mission at our statement, or our vision at our center is to transform rural and Native American health. So I'm like, our vision 12 years ago is aligned with our HCP. But anyway, so back to your question. When we started the center, one of the things I was really insistent on with my team is, where are the opportunities, right? Because you can't boil the ocean. You can't do everything.
No, you can't.
And I knew as a venture capitalist, one of my favorite sayings as a venture capitalist was, entrepreneurs have a great ability to discover solutions for problems that don't exist, right? So I'm like, we're not going to go after problems that don't exist. We're actually going to go find the problems. So one of our very first things we did is we interviewed over 250 rural providers throughout the state of Oklahoma, physicians, office managers, nurses, and said, what are your major challenges for delivering care in rural markets, right? That then became the foundation to align all of our innovation effort behind some of those major areas. I'll highlight a couple of them for you, right? So two of the biggest ones is the lack of primary care, right? So there's a shortage of primary care in rural markets, number one. Number two is the lack of specialists. I call it the lack of ologists There are no cardiologists, neurologists, oncologists, nephrologists. Pick your favorite ologist. They're just not there, right?
Lack of ologists.
Yeah,
I
call it, and we're actually written an article about it called "The Lack of Ologist" in rural America. So, lack of primary care, lack of specialist, or using my vernacular, the lack of ologist. To give you a stat, for instance, in the state of Oklahoma, we have roughly 800 doctors, primary care doctors, in rural. So, roughly about 800 rural primary care docs. If you do the math and said, how many primary care doctors would we need in rural Oklahoma just get us to the average number of doctors per rural citizen? We would need roughly 2,000 rural primary care docs to just get us to average, not even exceptional. We're currently at 800, so we have to get from 800 to 1,200.
Yeah.
We can't graduate enough doctors to put them into rural Oklahoma and solve that problem. It's not saying we shouldn't do that. We should continue to do that. But what we actually need to do is bring to market technology layers so that we can actually deliver healthcare with technology layers and then solve that second problem, which is the lack of specialists. And how do we actually use technology layers to bring specialty care into rural markets without worrying about bringing humans? And that's where Oracle comes in.
Yes. Okay. I was like, that's where it is. That's where the magic happens, and talking about that and bringing that technology in to layer in and then bringing in those specialists. So let's talk specifically about data in the Oracle EHR real world data. Now, this is a de-identified data set representing more than 129 million patients across the U.S. So why was access to data at that scale critical for building meaningful clinical tools? Talk to me a little bit more about
this. So we were blessed to receive that data early on. And so I describe it as we were doing predictive analytics before predictive analytics was cool. So we started 12 years ago.
Yeah.
We did it so far back that we called it just basic analytics, and then became predictive analytics, and then prescriptive analytics, and then machine learning, and now we call it AI, but we've been running the whole journey of it, right? What's really unique and nice about this data set is, unlike other data sets where you can find claims data sets like the Medicare claims data sets, or you can get Medicaid claims data sets, all of that really does is show access, that people are actually, going into the health system and accessing, and somebody paid a claim, right? The beauty of the data that we have through Oracle is it's all back-end clinical data, right? And you mentioned it was de-identified and HIPAA compliant, right? Which for me at a university means I can jump right into doing a data analytics project without having to go through IRB. It's IRB exempt. So I don't have to go in and get formal approvals to run the trial. I can actually literally, you and I could come up with a data project, and tomorrow we could start working on it because it's de-identified, HIPAA compliant. Whereas in the old days, if it were identified, not in the old days, but if it were identified data and not HIPAA compliant, we'd have to go through a whole institutional review board process, which could take as long as 6 to 9 to 12 months just to get approval to start the project, right? So because it's de-identified and HIPAA compliant, we actually can jump into the data immediately. It's clinical data, so we actually have relevant information about the patient. And the last thing is, and you didn't mention this, but it's one of the more important things, is the data set is longitudinal. So even though it's de-identified, it's longitudinal because every patient gets a unique patient identifier. And so that patient 11689457, whatever it is, that's William, right? And every time that unique identifier shows up in a health system that's running the EMR from Oracle, then it captures that data. So it's longitudinal, even though it's de-identified, which is so critical to do predictive analytics. If I just have a narrow snapshot of data, then I can't do anything with it. I need the longitudinal. Can I give you a quick case study?
You absolutely. I was actually going to ask you.
Is that the next question?
Absolutely can.
So to make it real, I'll give you a very specific example of a project we did. One of the biggest challenges in rural and Native American markets is diabetes. It affects the rural markets at much higher rates than the urban markets, right? If you're a diabetic, you're supposed to get an annual retinal eye exam for diabetic retinopathy, okay? And that's blindness from diabetes. The number one cause of blindness is diabetic retinopathy. The way diabetic retinopathy mostly gets diagnosed is the diabetic presents to his primary care doc. They say, "How you doing?" He said, "I'm doing fine, except for I don't see as well as I used to." And then they're like, "Well, remember I've been telling you for 5 years to go get your eyes examined to see if you have diabetic retinopathy," and they haven't gone because there is no ophthalmologist in rural. Remember my lack of ologists?
Yes.
So they got to drive to an urban setting to get the evaluation, and they're not going to do it. That's why they don't do it. So we took that data and we said, can we actually, just based off of the clinical data, collected in a normal primary care encounter. Can we develop a tool that will identify which of those patients are at highest risk for diabetic retinopathy? Right now, we're just looking for risk stratification. Eventually, it'll become a diagnostic, right? So we have a tool right now that will pull data out of their demographic information, their comorbidity information, and their laboratory data from basic lab data like a CBC and a lipid panel. It's a 14 variable model.
Okay.
And we can now predict with an AUC or whatever metric you want over, the current AUC is 80, 0.89. Sensitivity and specificity is over 90%. Now I can give a tool to a primary care doctor, because right now what they tell them is go get your annual retinal eye exam in case you have diabetic retinopathy.
Yeah.
Now I can actually say, based off your data, you're at high risk for diabetic retinopathy. And oh, by the way, if you don't do anything about it, you're probably going to have vision loss next year. That's a motivated patient who will now go get the ophthalmic care that they need in an urban setting.
That's incredible. And so is it fair to say that with Oracle Health that you all are doing things that weren't possible at one time?
100%. Because I get very, can I tell you one more quick story about the
One
data
more
set?
quick story.
Because I know we're on time.
Yes.
You asked for the interview, not me.
Okay, that's fair. But one more quick story. I do want to hear this.
So and it shows you the power of the data. So we originally built this tool. We went after 5 known variables. Okay. So things like, are you comorbid for other diabetic complications like diabetic nephropathy, diabetic, neuropathy? Was your A1C levels high? Was your blood sugar high? We built a 5 variable model based off of those. And we said, is this predictive or stratifying the risk of a diabetic retinal patient that has diabetic retinopathy? Turns out it was about 60% sensitive specific. So not very good. It was kind of a coin toss. Then we went into the lab data. Once again, it's clinical data. It's not encounter data, claims data. We dumped all of that lab data for all those patients that we pulled out of the data set, and we identified 9 additional variables that were highly correlated with the onset of diabetic retinopathy. We would call that artificial intelligence now. We were actually just calling it advanced machine learning at the time. We picked up 9 variables. When I added it back to the 9 lab variables, now I have a 14 variable model that gets me to the 90% sensitivity and specificity. That's the power of the data that you could not have been able to do if it weren't for the breadth and depth and longitudinal of that particular data set.
I love that. That is the power of the data.
Yep.
Thank you so much. It's always a joy to sit by you, and I love your passion. We need more people like you in this transformation of healthcare.